My name is Ryan Norton. My student ID number is 2104466, meaning that my assigned uh, impairment for the final assessment of principles of correct exercise is femoral acetabular impingement syndrome. Femoral acetabular impingement syndrome can be found when a bony protrusion either on the acetabulum or the head of the femur um, interferes with the correct movement of the head of the femur and the acetabulum, and makes for really painful hip movement. Um, as we can see, there's a couple different types of impingement that can cause a couple of different types of pain in different movements. But through damage to the labrum, brings pain, arthritis, and then altered movement patterns to get away from that pain and arthritis, which can cause pain in other areas of the body as well. The patient that we will be using today is 30, plays tennis, no histories of lumbo-pelvic hip complex injury. However, he does present with bilateral hip impingement. In static evaluation, we see knees valgus bilaterally, feet pronated bilaterally, lower back lordosis, and anterior pelvic tilt. In the overhead squat eval, we see excess knee valgus in the descent, excess feet pronation, but we see decreased squat depth, and we see the butt wink to attempt to go deeper because of that anterior pelvic tilt. Patient tests, all values are bilateral for this. Hip flexion at 92 degrees, that's very limited, with the norm being at 120 degrees or above. Hip abduction, 15 degrees, which is very limited. That should be more about 45 degrees. Hip internal rotation, 5 degrees, also very limited. That should be about 30 degrees as well. Muscle tests, gluteus medius 1, hamstrings 1, quadriceps 2, posterior tibialis 2. So we're getting the picture of this individual with a aggressive anterior tilt to the point that their hip impingement is coming from the bony protrusion as we spoke of, but nowhere, it's not being helped at all by the anterior pelvic tilt that's being shown, because that's making the top of the acetabulum that much closer for the head of the femur to interact with earlier and to cause decreased movement. So, through our assessment, we're going to try to aid with this anterior pelvic tilt that we see. So, the SMR on the adductor complex, we see knee valgus in both of our movements, or in our movement assessment and in our static assessment. The adductors are, um, at the very least, overactive, to the point that they are pulling the knees in. So we'll use a lacrosse ball in a lengthened position to the point that the legs out to the side, and then we lacrosse ball. The peroneals, because we see the feet pronation, because of this, we feel that the posterior tib and the anterior tib might be underactive, and the peroneals might be overactive to the point that they're pulling the foot into pronation. And SMR on the hip flexor complex. The anterior pelvic tilt at its very core is a minor hip flexion. And so hip flexors are not at 100 or not at 180 degrees throughout the movements of daily life with the anterior pelvic tilt. And because of this, we want to loosen those hip flexors. Same ideas here with the hip flexor stretch. We're going to be doing this through the test that we use for hip flexion, where you lay on the edge of the table with your hips off, and we let those legs hang. Use the weight of the legs to provide a good stretch for that hip flexor complex to really loosen it out. The hip adductor stretch will be done with boxes to the side of the patient, where we get it above about 90 degrees to the point that it'll be uncomfortable for the client to easily swing their leg on top of. We place the leg on top, make sure that they get in a correct position, and allow them to stay there and feel the stretch in their adductors. Strengthening techniques. We want to combat that knee valgus Then that sort of lower cross syndrome that we're seeing with the anterior pelvic tilt, the knee valgus, the pronated feet, with clamshells with the band to help strengthen the gluteus medius, which also scored a 1, so that's a great reason to strengthen it. And then we're going to be doing hamstring positional isometrics with the patient laying down, knee at 90 degrees, and pressing against in the 25, 50, 75, 100 um, ranges. And then once we get into integration techniques, we are remembering that this person is a tennis player. So they would benefit from a single leg depth drop from a 20-inch box. And so because this is a bilateral syndrome, we should be doing these bilaterally. And then as we advance into a tougher integration exercise to progress the patient, alternating lateral bounds are good for the lateral movement in tennis, can show the improvements in hip adduction or abduction and overall movement of the femur in the acetabulum. That's all I have. Thank you.